Good morning.
Good morning.
Good morning.
Good morning.
All right, everyone has some caffeine in front of them. Well, you won't need it because I'm going to get you going and get you on a ride here today. First of all, I'd like to thank Linda Conley and Yvonne for inviting me, bringing me here to Little Rock. This is my first time in the great state of Arkansas, and my wife prepared me and made me pack about 3 or 4 different coats. You know, you lose your thick skin living in Los Angeles, which I have for the past 15 years, where Christmas is 75 degrees, okay? And it's quite interesting to get back into cold weather. So first of all, I'd like to start by not only thanking them, but thanking all of you for being here today. This is a Tuesday morning. Many of you have jobs that you should be at, and to come out and celebrate and really increase your awareness about HIV and AIDS. It's a true passion of mine. It's been a passion of mine for probably my whole medical career. And I usually talk to groups initially about why I got into HIV medicine, because many people don't understand why you work in HIV, and many of you may have a similar story to mine. I was a medical student at the University of California in San Francisco in the early 1990s, which was really the height of the HIV epidemic in our country, and really at the epicenter in those days. And really those were the days when people were mainly dying of HIV, and really only had one medicine at that time, really two or three, the D drugs had just come out. But as a medical student, I began my medical education in a place where we saw HIV patients every day, at San Francisco General Hospital. And it really, for me, I think just prepared me for what I'm doing right now, because I developed a compassion and a passion for those patients, many of whom were just young men dying of this terrible disease, which we really had little treatment for. And you know, as I went on with my career, I didn't want to go into infectious disease or HIV right then, because at the time I was kind of young and, what can I say, naive and inspirational, and I thought I was going to go out and save the world. I'd just come back from Africa, being in the Peace Corps, and but you know what happened is I got married, had some kids, got a mortgage, and that changed a lot of that very quickly. So, but what I found was I didn't want to go into a field where everyone was dying. I didn't want to be an oncologist. You know, I didn't want to be an HIV doctor at that time. But what happened was when I started working in my first community health center, which is what I've devoted my career to, working in underserved communities like the one I grew up in South Central Los Angeles, in Watts, in Compton. You guys know about those places. I found that there was actually another HIV epidemic going on. And now we fast forwarded almost 10 years, but things had changed in terms of treatment. Now we had medicine that was working, people were living. But unfortunately, in these communities of color, Black and Latino, this same effect wasn't happening as quickly. And people were still suffering from HIV and AIDS, and not just because of the medical illness, but also from the stigma, the discrimination, the depression, the anxiety, etc. around it. And I kind of grasped onto that now practicing in the community. And I'm a family practitioner, so I treat patients who are non-HIV patients, and also, you know, our HIV patients, and have learned how to integrate both. So, and I've really developed that as my career. My focus now is really getting the general community, other primary care doctors, to be able to manage HIV patients, to take that on, and get everyone involved, because, again, it's not just the medicine anymore, as we'll talk about. It's not just the illness, it's really the outside influences that really have the greatest effect on our patients now. And all of you in HIV care know exactly what I'm talking about. So many of you I'll be preaching to a choir, but hopefully we'll continue to inspire you to do the work you're doing, because we still have a lot of work to do. A lot of work to do, even though I think on the radar it's not there. So, moving forward, do we have an advancer, or do I just... I guess I can go this way. So I usually begin my talks with a quiz, and this quiz states as follows. Magic Johnson tested positive for the HIV virus in 1992 and is now cured of this virus. So all of you can participate. A, it's true, he's rich and can afford the best medicine. B, it's false, he's still infected but is controlled on medicine. Or C is, I don't know because I don't follow football. Now I know all of you in this business know the correct answer is B, thank you. But the issue at hand, I think the really overlying theme is that if If you walk outside this room and ask the average person on the street the answer to this question, you'd be surprised how many people will say the answer is A.
Yeah.
Because we see magic on TV, on TNT, talking about the NBA, fat and happy and rich, and think, oh, he's got HIV now, he's beat that, it's over. But people don't understand, the man is still HIV positive to this day. He has the virus in his body. He just does what every patient can do, whether you're rich or poor, which is takes his medicine every day, remains adherent, and is undetectable. And since he's been diagnosed now over 20 years, he's had 3 children since that time with his wife, Cookie, who is HIV negative herself. And that's the reality of living with HIV today. This is the other slide I like to begin my talks with. And those of you who heard my talk last night saw this one. And this is really a testament of how far we've come. And I put on the top, we've come a long way, baby. Because what you're seeing is an educational placard. It's a big tablet that you would show to a patient to talk to them about HIV. And what struck me about it, I found it in the back closet of our clinic, which has had an HIV program for over 20 years. And someone had thrown in the back, we were renovating and cleaning out boxes, and they were going to throw it away. And I said, no, we need to keep this, because this is really a relic of times past. Because what you see on the cover is what struck me. A cemetery. And I can't think of any medical illness where you would sit down with a patient and say, this is what you have to look forward to with your disease that you've just been diagnosed with. Not with diabetes, hypertension, even a cancer patient, you're not going to show them a cemetery. You give people hope. You give them faith. You give them some drive to try to get better. But in this era, this is how we felt about HIV and AIDS, which is extremely important. And we've come a long way from that. And I couldn't really find a date for when it was published. It wasn't in the literature, but all I saw was published in Waco, Texas. I don't know what that says about the great state of Texas, but the attitude in that time, in that era, was extremely disappointing. But we've come a long way from that. And I'd like to talk about this. What does HIV look like? Because again, this is what defines HIV for many of our clients in terms of themselves and the general public, which is wrong. And the question is, what does it look like? Does it look like 2 gay men at a gay pride parade, etc.? Does it look like these drug users shooting up dope, sick and dying? Does it look like these poor patients in Africa dying of AIDS and HIV? That's not HIV. HIV is this. It's a virus. It's a microbe. It's what's called a retrovirus. It's genetic material. It's based on RNA, not DNA. And as all viruses must do, they have to use a cell, in particular the CD4 T helper lymphocyte cell, which is one of our white blood cells, really the soldiers in our immune system that protects us from disease. It infects that cell to make copies of itself, because it can't copy itself. It can't reproduce on its own. It has to hijack that cell. It makes millions of copies of itself, burns the cell out until it dies. And over time, what that does is kills it. But HIV looks like this. People living healthy, normal lives right now in 2015. Like this man, as we talked about. This woman is Marvelyn Brown. She's an HIV activist out of Tennessee, who got HIV when she was 19 years old from her first boyfriend. She wasn't promiscuous, she wasn't a drug user, a college student. She got it just from trusting someone. And the issue is that we've taken HIV from what it really is, which is the science of it, which is just a virus that we can treat now, and we've made it into all these other things, these boogeymen, that I think really has a huge influence on how we can take care of our patients. It influences the medical community. Many doctors don't want to deal with HIV patients because they have all these other issues that they're uncomfortable with, rather than breaking it down to what it is, a virus that we can treat. So what is it again? The human immunodeficiency virus attacks the immune system. A person is very sick over time. When that virus depletes those T cells, those white cells, the patient ends up acquiring AIDS, the acquired immunodeficiency syndrome. And remember, every patient with HIV does not have AIDS. They're 2 separate conditions, technically. Someone can have the HIV virus or HIV disease and not have AIDS. Remember that. Okay. AIDS is really the end stage of HIV infection. It can take anywhere from 3 to 5 to 7 years. Some patients, even longer. Some patients never get to AIDS even without treatment because they have a specific genetic makeup. Just a little HIV 101 for those of you who aren't into the science, but it's important to understand that for any HIV patients, the two things most important, two numbers they always need to know, is what's their T cell count, right? Their CD4 count, because that tells that patient and the doctor how strong their immune system is. 500 T cells or more is a normal immune system with a good armamentarium of CD4 cells. Less than that, between 499 and 200 is a weakened one, but still effective. Less than 200, by definition, is AIDS, a very weakened immune system. And I've had patients with 0 T cells, 1, 2, or 3. I made a joke, one of my patients, he said when he had 3 T cells, and he kind of laughed and said, yeah, I'll call them Huey, Dewey, and Louie. Those are my 3. And I'm going to take care of them. But now he's got a whole team. He's got an army now. Because he got on medicine and got better. Because the good thing is when you get on medicine, again, those T cells can come back. The viral load is the other important number that every HIV patient should know and every provider should know. That tells you how much virus is really floating around in the body. And this is how we gauge treatment in HIV. When a patient gets on medication, the expectation is that high viral load, which can be as high as 100,000 copies of virus in 1 cc of blood, you can drop that down to undetectable levels. Really what we call less than 50 or less than 20 copies now with our test. So that means that in 1 drop of blood, even though the virus is there, the medicine has it controlled so well that you can't find it. It's undetectable in the blood. That's where Magic Johnson is right now. That's the successful treatment of a patient with HIV. And there's so many benefits to a patient when they're undetectable. It's really spurred why we treat HIV so early now and do it so aggressively. How does it spread? Let's review that, because again, a lot of the stigma with HIV comes from people not understanding and really getting that it's only spread 3 ways. Through sex, either anal, vaginal, very, very negligible transmission orally through sharing contaminated needles or even sometimes needle sticks, or from an infected mother through her unborn child, typically during labor. And really, the key is HIV is in the blood, in the semen, vaginal fluid, and breast milk. Mainly the blood. That's where most of it is, in the semen, in someone with a high viral load. What's not infectious is what really people need to understand. It's not in the stool, it's not in the nasal secretions, it's not in saliva, sputum, sweat, tears, urine, or vomitus, unless those fluids have blood in them. Remember, blood is where the virus is. So you can't get HIV from kissing someone, from eating after someone, from drinking after someone, from touching, etc., because it pains me so much when I hear people still, in this day and age, talk about, oh, I can't sit on that toilet seat because somebody with HIV was there. Oh, I can't eat after them. Oh, can I kiss them? Can I touch them? Etc. I have a story. I have a patient of mine who was with his family, and apparently his little cousin got a cut and was bleeding, and he was going to help him put a Band-Aid on. And his family, no, you can't touch it. You can't touch it. I'm like, what are you talking about? Well, you have HIV. Well, so he's not bleeding. He's just putting a bandage on. That kind of ignorance is what continues to make HIV patients feel discriminated, ashamed, and sometimes not want to deal with their own diagnosis. So it affects health and your ability to be well. So let's talk about some epidemiology. The fact of the matter is, HIV cases, and AIDS and death from HIV, the diagnosis of HIV, obviously, from the 80s to the early 90s, was continuing to rise, as did the number of people dying from HIV in red. But about mid-90s, we came up with combination therapy, a cocktail of medicines to finally effectively treat HIV. And you saw now a decrease in people dying of HIV, fewer diagnoses of HIV and AIDS going down. And what we're seeing because of that is, in green, a higher prevalence of people living with HIV. So this actually is a good thing. This means people are living. This number going up means more people with AIDS and HIV are living longer, right? And these going down are also good things. And we'll talk about that. What's been going on since we call it the ART era, which is the antiretroviral therapy era, when we started treating HIV effectively, patients are living longer. And we see that since the mid-90s here, you can see that the deaths for HIV have been dropping precipitously into the next decade as we had more people getting on medication. So we know our medicine works well. And with that, more people living with HIV, taking medicine, doing well, what they call the percentage of people living with HIV who are older is going up. In fact, now, in 2015, half the people with HIV in this country are 50 years and older. 50 years and older. And it's interesting because I feel like doctors like myself, who are primary care doctors and HIV specialists, are well suited for this population because we treat the people getting those diseases of aging: high blood pressure, diabetes, hypertension, congestive heart failure, you name it. Everything as you get older, arthritis. Everybody raise their hand, arthritis, we know about that, right? It's cold. Those are things that we treat anyway. So now, most of my well-controlled HIV patients, their HIV is really something that, we just check on their T cells, their viral load, they're doing great. Now I'm dealing with everything else they have. What's going on? However, there are a few caveats to that, because having the HIV virus itself is a risk factor for increased inflammation in the body and sometimes a higher risk for some diseases, so we have to be a little more careful with those. But in general, patients are doing well and living longer. And we know that the life expectancy for patients with HIV has increased since that time. Even in the last decade, you've seen patients now, and it's really postulated that if a 20-year-old person right now gets infected with HIV, gets on treatment early, they'll live to be at least 70. And that's really the name of the game right now. The fact is that people with HIV can live a full, healthy lifespan with HIV once they get it controlled. That's the key. And the key is getting patients in care, on medication, and undetectable. That's the hard part now for all of us, and all of you who do HIV work, not just in a medical facility, but outside, keeping patients in care and on their medicine, because they'll do fine. They'll live as long as anybody else. And I hope to live to 70 years old, right? Myself. So where are most of the HIV cases in our country? The darker the area is the higher the incidence, the prevalence of HIV. And you see most of it concentrated in the South, the Northeast, down here in LA where I live, in certain urban areas also. And again, the question is, do we have the workforce, do we have the capacity to make sure we take care of all these patients in these areas? You can see Arkansas right here, right? Kind of a mixture. These are the highest rates of, incidence of HIV in the country per urban area. And I just point out again the geography. And you can see the cities with the highest new infections. This is 2011 CDC data. But again, the top 10, at least 7 or 8 of those are cities in the South. And knowing that here in the South is where we really have to focus our efforts for much of what's going on with HIV. And we'll talk about why later on. But again, Miami, New Orleans, Baton Rouge, Jackson, Mississippi, DC, Baltimore, Memphis, Atlanta, etc. People always talk about San Francisco, associate that with HIV and AIDS, but San Francisco doesn't even crack the top 20 in terms of new cases. And that's really a testament to how aggressively they addressed HIV in cities like San Francisco. If you've been to San Francisco, you'll see advertisements about HIV everywhere. Condoms, big penises everywhere, like, protect yourself. It's very, very serious. But unfortunately, I think places where people don't want to talk about it, you've got this problem. And I always hear, I went to school in Atlanta, at Morehouse. I know, the South, a little different. People don't like to talk openly about a lot of things. But unfortunately, that silence can hurt the epidemic itself. So all of you in this room, that you're being here, make sure you're vocal. Make sure you see something that needs to be addressed, that you need to tell people, hey, HIV is not gone. Just because Magic's doing well doesn't mean everybody's doing well. They're not. That we still need to keep working hard to keep people in care. When we look at populations affected by HIV, we still have most transmission is through male-to-male sexual contact, what we call MSN. A certain amount of heterosexual contact, mostly in females, because women can only get it from a man, right? Some males do get HIV through heterosexual contact, but much less. Injection drug use is really a smaller percentage. As you can see here, only about 5% of HIV, 5% of men, and 3% in women. In other cases, about 1%. And one thing I need to define, one of the issues we've had with prevention strategies with HIV over the years has been that the definition of male-to-male sexual contact, again, it's not necessarily something to do with that lifestyle, but it's more the way that men have sex. Our anal intercourse is the highest rates of transmission, especially if you're the receptive person on the bottom. You're the highest risk for HIV. And again, I'm going to talk very openly and real, but when you talk to your clients, knowing that if you're having anal intercourse, and even females having anal intercourse, because that's really a hot thing now, for everybody, is the fact that that is the highest rate of transmission of HIV, because the rectum is a very, very sensitive area. The tissues and the mucosa are very absorptive for the HIV virus. So patients need to understand, if they're having anal intercourse, they need to protect themselves. Okay? And MSM, this is the term. And the reason they use that is because we don't say gay anymore, or homosexual, because, all men who have sex with men are not gay. And that's to be understood. A lot of people don't understand that. Remember, gay is more of a lifestyle, it's more of a culture, it's more of a kind of environmental thing. Because there are many men who have sex with men who identify as heterosexual, or say they don't go to gay pride parades, they don't go to a gay bar, they don't, watch Madonna and Diana Ross and everything like that. That's not what they do. They're just men, and they like to have sex with men sometimes, or that's their preference. But they're not gay. You understand? There's also, and what I've understood, sometimes in men who are incarcerated for a long time, the idea is that if you're the person on top when you're having sex, you're still the man, because you're not getting penetrated, right? And there's the issue of you can still be there, have sex with a man, and not be gay because you never got penetrated. Or how Chris Rock said, got your salad tossed, right? So the issue is that we have to understand these different nuances for prevention, for communicating with people, and be open and non-judgmental. Because the key is when we bring judgment into things, people don't want to talk about things. And just be very open. I talk to my patients when I see them. So, are you having sex? Yes. Well, you have sex with men, women, or both. Just say it like that. Are you having sex with men? Really? No. It's just make it just a nonchalant part of the conversation. Oh, really? Okay. Well, are you a top or a bottom? Which one? Because when you make it like it's just a normal thing, people don't feel so anxious about it or worried. And that can be huge in terms of getting someone to open up, and then you can address the risk. Because that person may not know. Well, if you're on the bottom, you're really at risk for getting HIV. So why don't you think about, make sure you use a condom if you're going to be on the bottom. And not say, they said you shouldn't do that. No, that's not going to help that person. In terms of race, this is the other big disparity, and one of my passions is the fact that HIV is disproportionately affecting African Americans in this country. If you look at 2013, the latest CDC data, and took in new HIV cases, African Americans make up almost 50% of new HIV cases in this country. HIV is becoming an African American disease in this country, in the United States. It really is. Caucasians about 30%, Latinos about 20%. When you compare that to the general population of our country, all 300 plus million, which is 63% Caucasian, blacks only 12% of the population, but yet 50% of patients with HIV. Huge disproportion. And there's lots of study into why that's happening, what's going on, why are African Americans so disproportionately affected by this. This is some data, a little older, but the reason I put this slide up is because the way it's presented, it really shocked me when I really started doing this, and just kind of fueled my passion for treating those patients and addressing this in my community. Now, I don't think anyone's a math whiz in here. This is really prevalence data, people living with HIV. This is a little older, but still true today. And it looks at prevalence data, which in epidemiological terms, you put over it's a fraction per 100,000 people, how many people are living with this disease. And if you look at black, in red, men, the prevalence is 2,300 per 100,000 population. So if you do the math, you take 2,000 over 100,000 as a fraction, and you reduce that fraction down, right? That works out to 1 out of 50 African American men is HIV positive in the United States. 1 out of 50, which is shocking. You do that. If you look at African American women in gray, 1 1,000 per 100,000 and do the same reduction. That's 1 out of 100 African American women is HIV positive in this country. Latino men, about 800, you could round that up to 1,000, over 100,000, that's about 1 in 120 Latino men is HIV positive. Now again, that's not everywhere. There's more concentration of people in certain areas as we talk to some of those cities. But overall, it's frightening. And the issue is that many of those people are not in care, and that's what we have to work for. When you look at new cases, this is more recent data, 2013, again, new infections of HIV in the United States. If you look at the total new infections in 2013, 47,000. And again, this number, about 40 to 50,000 new cases every year. That number hasn't changed. The people dying of AIDS has gone down, etc. But the number of people, new infections, pretty much stays steady. So it's like there's something we're missing in terms of why we still have 50,000 Americans still infected every year. If you look at that and break that down by transmission mode and by race, unfortunately, black MSM have the highest number of new infections. White MSM, men of sex with men, right behind them, and Latino third. Unfortunately, MSM the highest group. But when you look at heterosexual transmission, black women leading the way here. So African Americans, unfortunately, vary 3 categories, and these are intravenous drug users, a much smaller number. This number has actually been very low ever since we started doing needle exchanges and really increased the way that patients who are intravenous drug users can get their fix, and really kind of correcting that. But other areas in terms of sexual transmission, still high, still extremely high. Speaking of this, and the reason I think that's important is because that's an area that, since we've had success, I don't know if you guys heard about the outbreak of HIV that happened in rural Indiana earlier this year. It was a small town in southern Indiana where they came up with about 70, 75 new cases, I think maybe over 100, of HIV. And these are all Caucasian, white people, getting HIV. And all of them, unfortunately, were IV drug users in this small town, which had a depressed economy, and many people were addicted to, and this ties into our medical community, they had originally addicted to prescription opiates, our oxycodones and Vicodins and Norco, you go on and on. The patients come banging on my door for them, But then the next step after that is, when you can't get those, heroin. Or even taking those pills and melting those down and shooting those up. And the fact that since Indiana didn't have any type of needle exchange program or any way for people to get needles, they would just share the needles rather than dispose of it after they used it. And really had a rash of HIV that broke out. It was a huge, huge issue, really addressing how do we address this topic. And in fact, just the FYI, heroin is back. Just so you guys don't know that. It's the new thing now. That's what's really coming up from Mexico and other places now with the drug cartels. Crack is kind of whack, now it's heroin, unfortunately. Believe it or not, we're back in the 70s, right? With the junkies on the corner, now the heroin is back. For some reason, it's crazy. The group at highest risk right now, who unfortunately have the highest rates going up, are young African American MSM, and this is CDC data, looking at a trend earlier, a few years ago, from 2008, 2011, where they saw most other groups fairly level, but young African American MSM, 13 to 24, still with the rising number of cases. So again, an issue about how do we address this group and their needs and their risk. And that's something, again, all of us have to look at ourselves and say, when we look at a young man who may be coming into his sexual preference, to make sure that he understands the risks that are involved with that. And that he has a community out there that's there to help him. The next highest risk group is black women, although they were the highest risk group, but the good news is that actually has leveled out over the past few years from the latest data. And I don't have a slide for that, but just know, among African American women, things have gotten a little better. Let's look at Arkansas. So this is just a slide from actually if you go on the internet and look on your health department, state health, they have an HIV report every 2 to 3 years. This is right from that. Really showing that the highest number of cases are in central area, which is, I think we're right here, Pulaski County, right? That's where we are. So right in this area, where most of the cases with AIDS and HIV, but you have it in every corner of the state, just smaller numbers. And so the issue, again, I think to address this is you've got patients living with HIV, maybe way out in some rural county. And how do we know that that patient is in care, getting care, et cetera? Or who they may be having partners with, et cetera. And as a state, again, statewide, I don't know, we're in Little Rock, I know people here are more involved, but are they having a conference like this way up here in Madison County? Who knows? Probably not, right? She's like, oh no. But the issue is that the awareness needs to be there. So all of you, if you're from these other areas, make sure you take these messages out there, educate people there to know what's happening, and help them to seek care. One of the issues that's been noted in, say, the rural South is that patients who may be positive living in a small town, many times because of stigma and discrimination, they don't seek care, or they seek care hundreds of miles away in another town, even another state, because they don't want anybody in their town to know. Because, for instance, they go to a local pharmacy and they pick up their HIV medicine, somebody working there might be related to somebody they know or somebody they know, et cetera, and then all of a sudden, everybody knows. And so that can it's a huge, huge issue. And in terms of the conference, I know some of the disenfranchised populations, many people leave their small town, go to, say, the bigger city. This happens a lot like in Atlanta. They'll leave a small rural town to go to the big city. Many times with no resources, end up homeless, et cetera, end up falling into a lot of those things that happen, drugs, alcohol, et cetera, abuse, prostitution, et cetera, to survive, which complicates treating their HIV disease, which could be treated with some stability in their lives. This is looking at our HIV in Arkansas, the last reporting year, 2013. Most of the cases were in men, about 80%, 77 to 80%. Most of them in African Americans, at least 50% in Arkansas, the patients with HIV were African American for the most part. In age group, mostly from the ages in here 15 to about 35 or 40, most of the cases, young people. If you look here, new HIV cases in Arkansas, ages 15 to 24, were about 36 to 40% of patients were right in that young age group. So patients who are just starting really in their sexual lives, all of a sudden getting HIV. Again, how do we address our youth in terms of this disease? So why do we have these disparities? And there's multiple factors that risk this disparities, especially by race. Why are African Americans 50% of the cases of HIV? And only 12% of the population. There's multiple studies that have looked at this, socioeconomic issues, poverty, incarceration, drug use, lack of access to care. One of them is the lack of awareness. That's what we're here today. Get people aware. HIV is not gone. It's still here, right? 50,000 cases every year in the United States. Sexual networking, because in general, people tend to have sex with people of the same race. High rates of STDs, which can actually speed the transmission of HIV. If someone has a concurrent infection, like chlamydia, gonorrhea, HIV is much more easily transmitted through the genitalia. And then stigma is a huge one, too. High rates of unprotected sex, we see that, unfortunately, especially our youth, our African-American youth. And also the fact that, again, this idea of networking. If you're an African-American in a high-risk community, you tend to have sex with other African-Americans, your chance of coming across someone with HIV is much higher, right? So that's the idea of networking with the same people or the same environment. At the conference last night, a young lady mentioned that at her school, she's a school nurse, she's here today, but she said that she had to counsel a young lady in high school who said she just had sex the day before with 2 guys, right? Mm-hmm. Both of them, one and then the next, and the guy hopped on her and did it again. This girl, right? She was 15, something like that. And the idea that, of course, was there a condom there? Probably not. The idea that these youth not thinking, what's going on to have that happen. So the risk very high. HIV is a disease of poor people in this country. Poverty has a huge influence on the transmission. We've seen this association. If you look at HIV prevalence, the percent of people living with HIV in U.S. poverty areas, and you compare that to other, what we consider third world countries, the rates are just equivalent. Remember, not every poor country in Africa has high HIV rates. Some have rates just as much as we do in our poorest areas. So he said, we still haven't solved this problem. And if you look at HIV prevalence by household income, you can see that the poorer you are, in terms of an income, say less than $10,000 a year, the higher your risk or rates of HIV. Really, it's a disease of poor people for the most part in our country. Stigma is huge too. And I borrowed this slide from a colleague of mine. She works at the University of Alabama, Birmingham. And she took this picture in Birmingham. This was, maybe about 10, 12 years ago. But the idea is that if this church, which you consider a place of solace, a place of support, a place where you go for help, if this church is advertising something like this, that's the last place you're going to go, when you really need something. And the fact that the community was okay with this, I mean, if they put that up in Los Angeles, someone would burn that sign down really quickly. But for this to sit there in Birmingham and nobody care, it's like, oh, that's okay, that's right, yeah, that's right. Think if you're someone who's at risk for HIV or has HIV, you think what are you going to do? You're not going to say anything. It's going to affect, really, how you can address your own health. So it's a huge issue, the idea of stigma. And just going forward, the idea of stigma and access to care. This is also from my colleague in Alabama. She took a picture. This is an HIV clinic in Montgomery there. And the idea that, of course, it's in this really kind of decrepit shopping mall. It looks like a marijuana dispensary in LA, but it's kind of this really shady looking place that nobody wants to go to. And you think, again, if you're a patient who's seeking care, wants to get tested, you're not going to go to a place like this. And the problem is that everybody in town knows what that place is, right? And so then if you're seen sneaking in there, your car parked out front, all of a sudden that raises suspicion for you. So the idea of stigma and access is also huge. This is the point. STDs. Another crisis that I deal with, not just HIV, but STDs. This is actually data from LA County Department of Public Health. And this is showing the rates of chlamydia in LA County in 2010. And what you're seeing is by race and by age. And these high bars shows the prevalence rate of chlamydia in this group. You see the incidence rate. And the highest groups are young, 15 to 19 and 20 to 24, yellow, black patients, black females. Highest rates of chlamydia, fortunately. Again, the STD is increasing the rates of HIV transmission. This is the rates of gonorrhea. It's equivalent. And this is LA County. I'm sure I could mimic this in several cities around the country. But the fact is that this higher risk of STDs increases your risk for HIV. It really is a marker for unprotected sex, especially in our youth, these two young groups, age groups, 15 to 19 and 20 to 24. So a huge impact can be made on HIV transmission and all STDs if we really can address this in that group of patients. So what are some of the barriers to care? We kind of just reiterated: poverty, inadequate health insurance, which can limit access to care. Many people are afraid to admit that they engage in MSM behavior, as we talked about. Some people distrust the medical profession. In the African American community, we all remember Tuskegee experiment. And, it's hard for me to sell a flu vaccine to half of my patients because they think it's some conspiracy, for patients. They don't, oh no, don't give me that. You're not gonna kill me, doc. Oh, no. Many people rely on family or church for advice, and sometimes family, remember, you can't trust everything your family says, right? And sometimes the church doesn't offer the best advice. Just pray on it. Well, what about this? I need some help. And we have churches like the one I showed you in Birmingham. That's not where you're going to get any good advice. Just don't do it. Okay. And then the idea that people with HIV don't need to see a doctor because they don't feel sick yet. Not understanding that we treat HIV immediately. That's the good standard of care. And sometimes they don't have enough community-based people, advocates, who can educate. Again, why you're here today. Because you're this group here. What you take out to the community is going to help the general population get a better understanding of HIV and what it's doing and what can be done about it. Now let's talk about treatment. We have successes in treatment now. There are over 30 medicines right now to treat HIV. I'm not asking you to memorize this. I'm going to quiz you on this after the talk, so just get ready. But the idea is that we went from one medicine 30 years ago now to over 30. We don't use most of these now anymore. Many of them are kind of antiquated. Many of the early ones had lots of side effects, had a huge pill burden and a really difficult dosing schedule. But the good thing is that we've been able to use these medicines in combination in a cocktail to help treat HIV. And this is a quick HIV primer for those of you not in science. I mean, you guys remember, you guys taking biology, cell biology. This is a quick one. It just explains what happens and why the medicines work. So what you're seeing is a T cell, the CD4 cell, This is the nucleus of the cell. This is the chromosomes where the genetic material is stored as DNA. And what happens is the virus has to attach to the cell in order to enter the cell. And there's certain medicines that block the virus from acting there. It has to copy its viral RNA into DNA. Right? It has an enzyme that does that. And some of the medicines actually work here to stop that from happening. It has to integrate this DNA into the cell's nucleus where it will be copied by the cell. It actually uses the cell as a factory to make more viruses. By starting here, there's medicines that are called integrase inhibitors that block that from happening. And then the final step is what's called the protease enzyme, which actually completes the viral protein. And there's medicines that work here. And so in order to treat HIV, our medications actually can stop the virus at several points along this cycle of production. And what we use is we have to use at least 3 different medicines that block it at 2 different places, or 2 classes of medicines. And that's how we get the combination therapy. And so the early combinations were huge. We're talking just tons of pills. In the early days, people were taking 20, 30 pills a day, sometimes 3 times a day with a myriad of side effects that were horrible. But we've evolved now. Now we've been able to use the newly developed medications, combine them into combination therapy or into single tablets. And we actually can treat HIV now with 1 pill once a day. 1 pill once a day with very, very few side effects. In fact, we have 4 commercially available 1 pill once a day options right now for a new patient. So the idea of, oh my God, I got HIV, I have to take all those pills. No, you don't. You can take 1 pill once a day and control your HIV, become undetectable. The key is you have to take it every day. That's the key. You can't cure it. Unfortunately, it's lifetime treatment, but it's still reasonable. Many of us take an aspirin a day, take a vitamin a day, have a cup of coffee a day. It's something you can do every day, right? And do well with it. And many patients are doing well. When to start, really we've refined that. Earlier in the treatment, we would wait until someone developed AIDS to start them on meds because the medicine was so difficult to take. But now, with the evolution of better medicines and understanding that treating the virus early is better, it's been recommended that you start medicine as soon as possible after being diagnosed. Whether your immune system is strong, your T cells are high, or they're low, you start. Because the idea, and I tell patients who come in early enough, I say, once you start, we're going to start you as soon as possible because with this you potentially will never get sick, never have AIDS, and you won't die from this disease. You're going to live that long life. I pull up my little charts and start showing them. You're going to live to be 70 years old. I don't care if you're 25 and you have HIV. You're going to live your whole life if you do this. Take your medicine. And we're going to start you now. With that, though, there are a few caveats. HIV infection itself and some of the medicines can have long-term effects, although minimal, but we have to be aware of those. And as a doctor treating patients who are aging with HIV, I have to be aware of these. There can be issues with higher incidence of certain cancers can happen with patients with HIV, especially if their immune system's already weakened. Remember, your immune system not only stops diseases, infections like bacteria and other viruses, but it also monitors you for cancer. Your immune system. So a weakened immune system, you can't have. There's evidence that there's a slightly higher rate of certain cancers if you're an HIV patient. So again, the earlier you get on treatment, the better. So your immune system stays stronger. HIV actually can get in the brain. Many of you from the olden days of HIV remember the condition of HIV dementia, delirium, etc. I mean, it can affect you. So the issue is, again, getting the virus low down quickly so it doesn't affect the brain cells. Cardiovascular disease can be slightly increased in HIV patients because of increased inflammation in the body. Liver disease actually now becoming the highest cause of death in HIV patients. So HIV patients aren't dying from AIDS anymore. Many are dying from liver disease. Many of them who have concurrent hepatitis C or hepatitis B infection. And all of you may know, hepatitis C is actually a much bigger problem in our country than HIV. There's about 4 times as many people with hep C, probably more than HIV. So, and if you're a baby born, if you're born between 1945 and 1965, don't raise your hand, it's okay. Make sure you get tested for hep C. Because our blood supply in the early 80s was not being tested for hep C, if you ever had a blood transfusion, and if you were kind of partying in the 60s and did a few things that you may remember, you should get tested. Because hep C can be very indolent and not know it. Okay? They may not know you have it for a while. Kidney disease and bone disease are also issues we have to be aware of. And other risk factors. I know there's a big push on smoking here. One thing that's a fact is that our HIV patients, unfortunately, have higher rates of smoking than the general population. And unfortunately, that's really a key to lifestyle for many of our patients. It's been proven through all age groups of patients with HIV, you have higher rates of smoking than matched groups of the general population, almost 50% more. And it's one thing I push on my patients, you know, you're dealing with HIV, why don't you get rid of these other issues that could be a detriment to your health? But getting people to quit smoking is a huge, huge, huge enterprise. And I'm sure the gentleman, you're speaking on smoking? No, okay, well someone's speaking on smoking here. That you're gonna address that. And it's a big, big, big issue. You are, thank you. HIV patients also have other risk factors. Higher rates of alcohol. A few HIV patients in blue, higher rates of alcohol use. Talked about higher rates of tobacco use, almost double. Higher rates of non-injection drugs, and that's your smoking marijuana and other drugs like that, methamphetamine, etc. And slightly higher rates of injection drug use. So our patients, some of their lifestyle issues are huge that we have to address along with them staying on the medicines and taking care of their HIV. And so the issue is, how do you address this? Encouraging patients to quit smoking, you know, talk to them about smoking if they're a smoker. I ask them every time, you still smoking, you know, and just kind of get them to talk about how we can help them quit, etc. And, you know, sometimes we have to offer therapy. I use Chantix, some of the drugs that we use for smoking cessation. Some of my patients, nicotine patches, etc. There are counseling programs that exist. And just talk about the issue of nicotine withdrawal, which is an issue because you're going to have to deal with that if they're going to quit. In terms of managing substance abuse, it's also a similar issue. You really need a team to do so. I mean, a physician can't do that by themselves in a 15-minute visit. And, you know, you have to draw in those other resources, social workers, case managers, psychologists, psychiatrists, etc., mental health people to help. And look at, you know, building those relationships and be persistent. You know, I have people who come on and off crack, on and off drugs all the time, and just trying to keep working with them until they can finally make it. You know, I've heard literature saying that, for instance, for smoking, it may take someone, a smoker, 7 times on average to quit and finally stay off cigarettes. So I tell them, if they quit, you know, they couldn't do it, doc. I said, try again. I couldn't do it, I tried again, do it again. Just keep trying. Eventually you'll get it. You just have to keep being persistent. And again, I think this is key. Don't have unrealistic expectations. Don't get frustrated or angry. Don't moralize your patients. Patients know that they shouldn't be smoking and don't want to. And you have a few say, fine, I like smoking, I don't care. But most do, and they want to quit. So just keep encouraging them. The other issue too is in terms of patients who aren't being tested and don't know they have HIV. If you look at the total population of people living with HIV in our country, about 1.2 million patients, about 25% of them don't know they have HIV. And the issue is that this group is responsible for half the new infections because they don't know. They're not sick yet, they just have unprotected sex, they're not taking any measures, and they just don't know that they're sick. The problem I have is that the 75% who do know they have HIV are responsible for the other half. And those are my patients who I try to counsel on safe sex and taking responsibility for the fact that they have something that they can pass to someone else. But the fact is I still have patients coming in with chlamydia, gonorrhea, and they're saying, doc, I'm using condoms, why do you have chlamydia? The condom broke. Well, why is it that every time you have sex, the condom breaks? You know, condom's that bad, why do we even use it, right? Doesn't make sense. So it just doesn't make sense. So people know, they're just gonna tell you something. Let's talk about testing. Now the good thing about testing is we know testing is the only way you're gonna address this issue. How do you find that 20% of people who don't know they have it? You have to test. Even people who don't think they're at risk, and I say that. Just a question, how many of you here in this audience have ever been tested for HIV? Just out of curiosity. All right, well that's a great crowd. Those of you who haven't, I want to see you tested next time I come back next year, okay? All right? It's important. Even if you don't think you're at risk, because you never know. You know, I have patients, some of my older female patients, you know, I'm not at risk for, they didn't think they were at risk for HIV, but didn't know that they, I remember one of my earliest patients when I started treating, she was a 50-year-old woman who got HIV from her husband of 25 years. And she'd never been with anybody else, because she didn't know what her husband was doing. And actually, it's a really crazy story. She found out, he ended up dying, got sick, was getting sick, went to the hospital, died of pneumonia, because per HIPAA, doctors can't tell someone without the patient's consent. And then when she buried him and looked at his death certificate, he said he died of AIDS. That's how she found out. Her husband was already dead and buried in the ground, and she's finding out he had AIDS. So she went and got tested and found out she was positive. So someone who was not at risk, you know, you have to understand that. A lot of my Latino women, in their Catholic culture, very loyal, very strict with marriage, etc., you know, most of them got it from their husband, you know. So it's really important to understand that anybody can be at risk. And it's a very simple test. You can get a test without drawing blood. And in fact, the CDC has recommended routine screening for HIV in all patients 13 to 64 years old since 2006. This is when the MMWR came out, recommending this. But it's not routine practice. And I asked those who said you've been tested, was that something your doctor offered to you? Or is it something that you just asked to be done? Or you got on your own? Right. So many times the medical community isn't buying into this, even though it's standard of care to test for HIV. Really, the only group that really gets tested routinely is pregnant women. I mean, women get tested more in general because they tend to go to the doctor more for gynecological reasons and pregnancy. But in general, most primary docs aren't just doing it routinely. I mean, I think it should be part of any routine test, and the key is it's an opt-out testing. That's what the law is. Every state now has changed. Before, to get tested, you have to have a written consent. I consent to be tested for HIV, and you have to sign this consent. Every state has gotten rid of that now. That you don't have to do a separate written consent to test someone for HIV. As a physician or a provider, nurse practitioner, PA, etc., you can do testing without a separate written consent. It's called opt-out. Basically what that means is you don't have to ask the patient to opt in. You don't have to say, can I test you for HIV? You can say, I'm going to test you for HIV unless you don't want me to. That's an opt-out. They can opt out of it. It's there and they can say, I don't want it, versus getting their permission to do so. Yes?
How expensive is a test?
HIV test? I mean, if you're doing it as part of a routine blood panel, it's negligible, right? Less than $20. Even the quick tests aren't that expensive. I mean, I don't know the exact price and what they charge here. Some of you from the organizations may know who do outside testing, how much those kits cost. But again, the thing is, it's been streamlined. You can do an HIV test with an answer in 20 minutes with a simple swab, and I think they're doing that. Yes?
Dr. Butler, I'd like to just announce that we are counseling and testing today, absolutely free. So you can receive an HIV test today. Cotton swab, 20 minutes, we won't stick you, and so you don't have to worry about that. It's a cotton swab that's 99.9% accurate, and it's going on in the private dining, absolutely free today.
All right. So hear that? So there's testing going on right now for free using one of the oral tests. No blood. There's others that use a finger stick just like you're testing for blood sugar, etc. They can test you. You can get an answer in 20 minutes right there for HIV. Other things that are coming along the pike are issues of medications that have long acting. These are still in clinical trials, but they're looking at some drugs, not just taking pills every day, but now getting an injection that will last 3 months at a time. So you get one injection every 3 months, like the Depo-Provera shot for birth control. That can control HIV. These are coming. These are some of the advances we're having, because we know how hard it is for people to stay in care and take meds every day, unfortunately, for some patients. So, again, 2 different medications in development for long-term treatment. And we know that treatment is prevention. If a patient is on medication and undetectable, their chance of transmitting the virus drops almost 96 to 97%. So you know the benefits not only to that patient taking it for their health, but also public health in terms of transmission outward. So getting into care has so many benefits, and getting on meds and getting undetectable, huge benefits, not only for the patient, just for society in general. So that's the work all of you are doing out here. So finding patients through testing, linking them and getting them in care, addressing their needs, which may be numerous, etc. And then again, preventative measures are out there. Before it was really about, let's do the ABCs: abstinence, be faithful, and wear condoms. I know we've tried to push A, that doesn't work. Come on, let's be real. It's a great idea, but it doesn't work. People are people. Kids are kids, right? Be faithful. Well, I'm not going to talk about that. And condomize, those have really been the mainstay of prevention for so long. But there's other areas that been out there. Of course the ABCs, but there's other. Circumcision has been found to reduce HIV rates, especially in Africa. Being uncircumcised puts you at risk for HIV because the foreskin tissue is much more amenable to the HIV virus. They tried diaphragms with medication that didn't really work out. We're now on the verge, we're now actually using what's called exposure prophylaxis, PrEP, which is pre-exposure prophylaxis, using HIV medicines, not a full regimen, but one of those medicines to actually treat patients without HIV. You can take it. If you're negative, take this pill and it'll prevent you from getting infected. Microbicides in females they could use inside the vagina to protect them. Really getting rid of all STDs in the genital tract, suppressing herpes infections, which can also bring on HIV, allows the virus to enter the body. And we're still working on a vaccine for HIV, which is coming. 5 to 10 years, we think we may have a vaccine to prevent HIV also. But right now, prime time is PrEP. can a pill prevent HIV? And there's a pill called Truvada. It's a combination pill that has now been FDA approved for prevention of HIV. And it's this was approved actually a couple of years ago, but the first drug to reduce sexually acquired HIV infection called PrEP. And we call it PrEP, pre-exposure prophylaxis. And I'm not sure if any of the organizations know if they're rolling that out here. I imagine someone's doing it. But this is for patients who are negative, who are high risk. They can take Truvada, a pill we normally use to treat HIV, but just take that pill once a day. You're here to protect someone from getting infected. Multiple studies have shown that it's effective. It actually works. It works in different populations. Intravenous drug users, it works in females, it works in males, and it works in MSM. It works in all groups. And so the debate is, do we still want to use condoms, or are we just going to rely on these pills? The problem is that this only protects from HIV. When I tell my patients, after people on PrEP, is that you still need to use condoms, because you're going to still get, it's not means you can take this pill and just go out and have a party. No, it means you still can protect yourself from gonorrhea and chlamydia and syphilis and all the other STDs. So it's very important to keep that in mind, that in every PrEP protocol calls for encouraging condom use and safe sex. Towards a cure, again, a cure is hopefully coming in the next 5 to 10 years, multiple areas. There's one patient who's been cured of HIV, this guy right here. His name is Timothy Brown. He's called the Berlin patient. He's the one man who has had a sustained cure for HIV. How'd that happen? Well, he was lucky. Well, unlucky, you could call it. He had actually lymphoma and had to have a bone marrow transplant. And all of you know that the white cells, the precursors, all live in the bone marrow, right? So he had to have a bone marrow transplant in order to cure his blood disease, his lymphoma. And when they did that, they actually cleared out all the white cells that had HIV virus in them. And he was transplanted with cells from a donor who had a very specific mutation. It's called the CCR5 delta 32 recessive allele. But this one mutation doesn't allow the virus to enter the T cells. The virus just can't attach to it because it's a slightly different shape of the receptor. But when he received that transplant afterwards, they tested him, HIV was gone, undetectable, off medicine. And they've been testing him now, it's been about 5 years, he's still negative. And so it's really amazing, but the problem is you can't do a bone marrow transplant on every patient with HIV. It's a very dangerous procedure, it's a very expensive procedure. And but not part-time, but what that did was lead to the idea of what research, it's led researchers to look at different pathways for cure. You may have heard of this case of the Mississippi baby. This was just down the road. This is another possible cure. This was a case of a mother who was HIV positive and pregnant, and she was kind of very irresponsible, didn't get prenatal care. She shows up in the hospital and delivers the baby right there. But what the researchers did, the doctors did at that time, was rather than they knew she was positive, they actually put the baby on full treatment for HIV, even though they didn't know if it was positive or not. Because really, transmission is through pregnancy is only about 35% of the time a baby will get HIV. But just to be sure, they just put the baby on a full treatment regimen right away, within 72 hours of birth. And what they found was that they kept the baby on this, and then the mother was coming to the doctor, but then she kind of disappeared again for about 6 months. And when she came back, they found that she had stopped giving the baby the medicine, right? So they were worried, oh my God, what's going on? So they tested the baby. This is now, the baby's about 18 months old. They found the baby was still negative and undetectable, even off medicine. So they said, well, maybe, did we cure this baby by treating it so early? But unfortunately, after about another, I think, 6 to 8 months, they found that the baby's viral load started to come back up. Because remember, the medications just stop the virus from making copies. It doesn't get rid of all the virus. It just sits there and you can't do anything when you take medicine. You remove your medicine, the virus will start again, its little factory, and the viral load will come back up. That's 6 months. And what's going to help? We maybe think the Affordable Care Act will help. I think that someone did tell me that Arkansas expanded Medicaid with the Obamacare, with the Affordable Care Act. It did. It did. So there's ideas thinking that may help in terms of addressing this epidemic, as people who were uninsured formerly can now get to a doctor and get tested if doctors will test. That's the key. So how do we get the healthcare community to then engage in this issue? And so allowing for more detection of patients and more treatment. So we'll see how that pans out in terms of the HIV epidemic. Unfortunately, there's lots of political opposition to that, as we know. And hopefully, and for me as an HIV doctor, I'm about health. I don't know what everyone's politics are, but I think it's very important that people have health care to address this issue. And then let's look at homelessness. I know we're talking about some groups that are disenfranchised. HIV patients have higher rates of homelessness than the general population. It's a huge issue for my patients, many of whom, again, because of stigma, discrimination, or their lifestyle, or their sexual orientation, have been kicked out of their homes. They've left their own communities. Many people show up in LA, it's like la la land, everybody wants to come to California, I'm gonna go out there and be free, et cetera, et cetera. But California's expensive, and if you show up in California without a job, it's not really happy for you, right? And many people end up homeless. The weather's nice, so you can sleep outside for most of the time. But the issue is getting people to care. It's hard to be on a medicine that you have to take every day if you're living out of your backpack under a bridge. And so the issue is how do you get people stably housed so they have a place to store their things, to have some stability in their life. So it's a huge issue for many of our patients. And again, homelessness leads to other issues in terms of substance abuse, et cetera, et cetera, et cetera. And it says even here, more than 140,000 people with HIV have some stable housing and have an unmet need of housing assistance. So it's a huge issue for our populations. And homeless populations do need more resources. They need complex case management, they need substance abuse treatment, mental health treatment. Many have food insecurity, and really high risk for non-adherence to their medical treatment and their medical visits. I think many of you know what I'm talking about, dealing with that population and trying to give people this kind of assistance. There's a program called Hopwell, which is also funded by the Ryan White Care Act, which is linked to HUD. Many patients can get Section 8 housing when they have HIV to help them. And there's funding for patients that are on SSI, SSD, disability, and through the VA. Actually, there's a lot of help there too. And then many times, because many minority patients need specific care that needs to be culturally competent. And it's important in our clinics and our staff have people understand the cultures they're dealing with. I'm in Los Angeles, we have a lot of Latino cultures which are not the same. Persons from Central America are not the same as somebody from Puerto Rico. Somebody from Mexico is not the same as somebody from Guatemala. You have to understand those nuances. Some patients, they optimize their treatment for antiretroviral therapy, and sometimes it's important to have those resources at hand. And it's really important for patients to stay on their medicine. That's the key. And again, the overlying theme is how to get patients in care, tested, know they have it, get them in care, keep them in care, get them adherent to their medicine so their viral load goes down, their T cells stay high, they don't get sick, they don't transmit it to other people, and then address their other lifestyle issues like smoking and substance abuse and mental illness, etc. And again, look at the stigma. I asked everyone to really look at your own self-stigma around HIV patients. The fact you're here means you probably don't have a lot, but what I tell patients, that's why I put this in here twice, audiences, is that your simple act of being here and what you say when you're outside can have a huge impact on stigma which is out there. When you hear someone say something ignorant or just hateful about HIV or about patients who may be at risk, etc., it's time to correct them, just gently if you need to, even if it's your relative. That patient with HIV, I don't want to sit next to them. It's like, well, why? They can't give it to you. Just correct them. Let them know. That's not appropriate. And that patient's going to probably live longer than you because you're still smoking. They quit, right? You can make these comments that are important. It helps everybody. Just remember that also other parts of the world have huge issues with HIV. For instance, homosexuality is illegal in 76 countries in the world, meaning it's in the law, and you can go to jail for being homosexual in multiple countries, especially in Africa, which is really the hardest hit area for HIV right now. And in some countries, sex workers who want to protect themselves with condoms can be arrested for having condoms because they're saying, you're doing sex work, you have condoms. No, does that make any sense? Right? Remember, it's a global disease, and we'll talk about World AIDS Day. Just forget this is a global problem. 2/3 of people with HIV are living outside the United States, most in sub-Saharan Africa. Some countries with prevalence, you can see over 10% of the population is affected with HIV in many of these countries in Southern Africa going forward. But we have some issues here in countries close by, so something to keep in mind. Asia also. Just some statistics. Again, 78 million total infections since the beginning of the epidemic. Now 35 million people living with HIV today, and still 2 million plus new infections every year, but this number is going down, so that's a good thing since the early days. So I'll end with that. I'll begin with this statement. The best time to plant a tree is 20 years ago because you already have fruit right now that you can pick, but the next best time is now, so it's never too late to get started and do the work you're doing. Thank you everyone for listening. If you have any questions, I don't know if I have 2 or 3 minutes for questions, and thank you very much.